Good morning. I'd like to welcome everyone to our session today, which is addressing physician sexual misconduct. Thank you all for coming. So I would like to begin by introducing our panel members today and myself. I'm Pat King. I'm a former chair of the Federation, a former member of the Vermont Board, and I also chaired the FSMB work group on physician sexual misconduct. If many of you may remember, we passed those recommendations in 2020, which was 2 years ago now. We were virtual at the time, so it's nice to have everyone back together again. And I see a number of our work group members actually in the audience today. And I thank you for your time that we spent over 2 years working on this project. So we have some great panelists today, and we're very privileged to have Dr. Tristan McIntosh and Ms. Myrna McCollum here as presenters. Dr. Tristan McIntosh is Assistant Professor of Medicine in the Bioethics Research Center at Washington University School of Medicine. Her research interests include cultivating ethical workplace cultures, professional decision-making, and ensuring responsible conduct in the research, development, and commercialization of medical technologies. Dr. McIntosh led a national project that was sponsored by the Greenwall Foundation that engaged 39 members of state medical boards across the US to generate consensus-based legal and policy recommendations that boards can adopt to improve approaches for protecting patients from physicians who inflict harm. The project also convened an advisory board that included, full disclosure, myself as the past chair of the FSMB, but also leading health lawyers, leaders of physician remediation training programs, a number of members of state medical boards and other stakeholders, all who helped inform the development of the recommendation. So we're pleased to have Dr. McIntosh here. Ms. Myrna McCollum is a MEDA lawyer from the Green Lake in Territory 6 territory of Canada and the host of the Trauma Informed Lawyer podcast. Prior to founding Mio Pematsuan Legal Services in 2019, she served as an adjudicator to the Indian Residential School Settlement Agreement claims process and Crown prosecutor with the Ministry of the Attorney General in Saskatchewan. When she is not visiting with her 3 grandchildren, educating, or podcasting, Ms. McCollum is advising, advocating, or conducting workplace investigations and reviews. In 2020, the Federal Department of Justice awarded her its first ever Excellence in Legal Practice and Victim Support Award. So it's a great pleasure to have Ms. McCollum with us today also. So I would like to begin just with a brief presentation on, to remind you all of our work group and to go over what our recommendations were. And then I'd like to finish up with highlighting a couple of state boards. There have been many changes for many state boards, but I just want to highlight a couple to give you a sense of change that is taking place already. So if you remember back, this slide captures a lot of what was happening in the 2016 to 18 time period. Summer of 2016 was the Atlanta Journal-Constitution series of articles on doctors and sexual abuse. And if you read this, you would have known that it was critical of state medical boards and the function at that time. This was followed with a number of very public and egregious cases of sexual misconduct, including Larry Nassar at Michigan, Richard Strauss at Ohio State, and George Tyndall at USC, among others. So it was in that background that in 2018, we established at the Federation the work group on physician sexual misconduct. And we had a what, why, and a how what were we going to do? What was our objective? We wanted to provide best practice guidance and recommendations to state medical boards for 2018 regarding physician sexual misconduct. When we started out, we thought we would be reviewing and revising our 2006 guidelines on physician sexual misconduct, but by the time we got to the end of our work, our scope had increased and changed so much that we had an entirely new policy. And finally, our aspiration was to change culture across the continuum of medicine. And we were just one part of that continuum of medicine. The why did we want to do this? We saw these egregious misconduct cases with abuse of power and trust. We knew that there was harm being caused to patients, and there was also harm to the medical profession. We knew we had to improve board function and make recommendations to better protect the public. And certainly at the onset, one of our major focuses was why didn't the boards know about these cases, and what could we do to improve reporting of physician sexual misconduct to state boards. And then finally, the how. We wanted this process to be grassroots and inclusive. We had a work group that was 15 people from 12 different boards. The work group met multiple times, listening and learning from the literature, from state medical boards, all of you at these meetings, from stakeholders throughout the House of Medicine, from survivors of physician sexual misconduct, which was really most impactful to the work group, and from subject matter experts. And finally, we really wanted to build consensus. Initially, we established some guiding principles: trust, professionalism, fairness to victims and physicians, and transparency to the public. And we also made a new definition for ourselves, at least, on what sexual misconduct was, that it is understood as behavior that exploits the physician-patient relationship in any way, whether that be verbal or physical, virtual or in person, and it takes place along a continuum. We knew that, especially from reading the literature and what had been gained from studying sexual misconduct. And then we knew that behaviors falling at any point along this spectrum were worthy of the attention of the state medical boards. So what were our key recommendations? We had 38 recommendations in our report, and the report is on the Federation's website, so you can go there for a lot more information. But I've kind of whittled this down to 6 big ones. So transparency was one. Transparency for the boards to be transparent to the public, both in process and especially in the written board actions. The board actions tend to be very vague with no real description of what went on. We knew we had to reduce barriers to reporting, and that was another area. We knew that public knowledge of medical boards had to be improved. We had that data from a Harris poll that the Federation did. We knew that the public submission of a complaint had to be easier and clear, but we also knew that we had to improve compliance for our profession, for our professional duty to report for hospitals and for physicians, report to medical boards cases of physician sexual misconduct. Investigations was another key area. We thought the board should have ability to impose interim restrictions and limitations on practice while an investigation was taking place. And we knew that, or we felt strongly that the board needed to be trained on the impacts and effects of trauma. And it was not only the staff, but the entire medical board who would adjudicate these cases. Discipline, we thought that, or we recommended that the boards should consider revocation for a single egregious act or for repeated lesser acts. And in terms of remediation, we knew there would be cases where remediation would be indicated, but we thought that should be detailed and rigorous and include long-term monitoring. Education was a big focus of ours. Education across the continuum of medical education and practice in terms of physician sexual misconduct, inappropriate interactions with patients. And then education also for patients. We heard this from our survivors on what to expect for an appropriate examination. Culture was a big part of our focus. In addition, we really wanted to increase medical board diversity, public member and training in implicit bias and trauma impact. I've already mentioned trauma impact, and we'll hear more of that from Ms. McCollum. And then we wanted to educate across the medical profession again to eliminate harassment of any type. So there are a few states I wanted to highlight on work that has already been taking place. The state of Georgia, in July of this last year, 2021, passed House Bill 458, and it went into effect in July, which included many of our work group recommendations. And remember, Georgia is the state of the Atlanta Journal, so they were keenly aware of these issues. So training for board members and staff on sexual misconduct, trauma, and implicit bias, allowing summary suspension of a license pending proceedings for revocation or other action. It required CME for physicians on sexual misconduct. It required education in the state's medical and osteopathic schools for sexual misconduct and proper examination. It required that all healthcare providers be required to report physicians who have sexually abused patients. That is duty to report. And the medical board also is required to report to the state on its handling of sexual misconduct each year. The Medical Board of Ohio is another state I'd like to highlight. After the Richard Strauss case, the governor of Ohio convened a work group to review an investigation of the handling of this case. And out of that came several recommendations. But the Ohio board has worked very hard to make a number of improvements. And I would direct you to their poster, which goes over much of what that they have done in the past year to year and a half. But here I just would like to highlight how they have emphasized duty to report. They had a duty to report by statute, but in 2019, they required attestation on physician licensure application regarding an understanding of the duty to report misconduct to the medical board. And in May of last year, about a year ago, they required licensed physicians to complete 1 hour of CME on duty to report. In addition, they've created a video course on duty to report, sexual misconduct, and how to report, and they've done a lot of outreach to practicing physicians and made improvements on their website for patients to report misconduct to the board. A lot has been done. And then finally, the third group I'd like to highlight is the Medical Board of California. They have really been a champion for enhancing transparency and information to patients, beginning actually before our report was approved in 2020. In July of 2018, they made availability an app to better inform consumers. This is an app, and participating consumers can put in up to 16 physicians that they would like to have access quickly to information. For those 16 physicians, the consumer would receive regular updates on status changes for physicians, including disciplinary actions or other public record actions. And then in July 2019, they passed the Patients' Right to Know Act, which was of 2018, actually. And in this act, licensees who are placed on probation for acts of serious misconduct must notify patients of their probationary status, and this includes sexual misconduct. So a lot going on. There's many other states who are active and making changes, but I just wanted to highlight these. And then finally, I won't read through these names. I see some faces in the crowd from the work group, but I do want to extend a very warm thank you to our work group members. I would add Michael Barron from the Tennessee board to this list, and a special thank you to Mark Stas for his support at the FSMB. So with that, I'd like to move on. That's our background, moving into this. And then I'm going to invite Tristan McIntosh to give her presentation. And thank you for being here. And do you want to sit or?
I will. Can I have access to the computer?
Yes, you can.
Thank you. So
And here's the.
drag it over, or do you just stand over there? I can stand. It's better.
No, it might not go.
Oh, I'll just stand. No problem. Make it my water.
Sorry.
No, you're fine. Awesome. Oh, and this is the clicker that we do. Awesome. Okay, good morning, everyone. Thank you for having me. Thank you to the FSMB. Today, I'm going to talk with you about a project that I've been super excited about and working on that worked with state medical boards for about the past year or so to develop a set of consensus-based recommendations that boards can adopt to do a better job of protecting patients from sexual abuse by physicians. And a lot of the recommendations that I'm going to talk about today align with the FSMB work group on sexual misconduct. Especially they speak to the notion of culture change in medicine and ensuring that matters of sexual assault and misconduct by physicians are not tolerated. So I'm going to focus on some of the recommendations that speak to that specifically. But before I dive into that, I want to give a quick thank you to the Greenwall Foundation who funded this project. I'd also like to thank my research team. They were invaluable, along with the project advisory board and several of the panelists who were members of state medical boards. Maybe some of you are in the audience right now, and of course the FSMB for their continued support of this project. So to give you a little bit of a roadmap of where I'm going to go today, I'm going to spend most of my talk highlighting a subset of recommendations that emerged from our project that our team at WashU did, where we engaged different members of boards to generate and evaluate recommendations for boards to better protect patients against physicians who harm patients. I'll focus on those recommendations that I thought were specifically salient to addressing sexual misconduct, and then I'll wrap things up by talking about potential barriers to implementing these recommendations, and then talk a little bit about some solutions and ways to overcome some of those barriers so I'm not leaving you hanging. So the basis for this project emerged from an earlier project that was conducted by my colleague Jim Dubois, who I believe spoke to the FSMB a few years ago. And it was funded by the National Institutes of Health, and his team examined cases of egregious wrongdoing by physicians. So when I say egregious wrongdoing, that's things like sexually abusing patients or performing unnecessary invasive procedures or unlawfully prescribing controlled substances. So these are behaviors that directly cause harm to patients and kind of undermine the core values of medicine. So the project convened a work group to review the cases and make recommendations for ways to address these root causes. And one of the recommendations was establishing more uniform and transparent actions by state medical boards. And excuse me just a second, I'm going to scroll down here, it froze. There we go. So more transparent and uniform actions across boards, that can help boards prevent egregious wrongdoing by physicians. And this is important because physicians are not quite like other professions, right? They have unique privileges and interactions sometimes that are intimate and require a lot of trust to be built and maintained and established with patients. So given the nature of these interactions, there's a lot of special oversight and consideration that's needed to make sure that patients are being adequately protected and not being taken advantage of or harmed by harmful physicians. So now you might ask yourself, well, how often do these egregious acts occur? And the answer to that is probably a lot more common than it should be. So only to be clear, only a small fraction of physicians commit egregious violations. So only about 0.5% are the subject of board disciplinary actions annually. But the rate of severe disciplinary actions is similar to the annual rate of new breast cancer diagnoses each year, and it's a much larger rate than new HIV cases this year. So you can see it's a pretty salient issue still, and these statistics reflect only those instances of wrongdoing that are actually reported. So the number of actual serious ethical violations is unknown and likely underreported. And this low reporting to boards, it might be due to a number of reasons, right? So patients might not have knowledge about what boards are, what their function is, and how to report or when it's appropriate to report. Sometimes patients might report to someone at a hospital or hospital system since it's more of a proximal reporting entity, and that sometimes ends up staying in-house and it doesn't always make its way to the board. So that's one barrier to entry. To complicate matters a little bit further, there's a 6-fold variation by state in severe disciplinary actions taken by boards. And put a little bit differently, that action is not always taken against an offending physician's license when it should be. So in several states, physicians sometimes return to practice after being on the receiving end of disciplinary action for egregious wrongdoing. So our project sought practical solutions that boards could adopt to address this problem and variability across boards in responses to egregious wrongdoing by physicians, including sexual misconduct. So to do this, we convened a group of experts, including board members and executive staff, to both generate and evaluate solutions that address these issues that I have listed here on the screen. So specifically, we sought to identify effective and innovative solutions that boards need to better encourage and enable reporting, to do a better job of thoroughly investigating and accused physicians and disciplining them in a commensurate and timely manner, to also deter physicians from engaging in egregious wrongdoing in the first place, and then also to protect and empower patients and increase transparency. So we worked with the group over multiple iterative rounds of surveys and meetings to reach a consensus about which recommendations were most important for addressing these issues here. And we asked for kind of game changers that boards could adopt. And this process yielded a list of recommendations that can be used as a guide for boards who wish to improve their existing practices or adopt new practices. So we had a fantastic lineup of panelists. So our goal was to recruit about 40 panelists, and we ended up having 38 panelists that represented about half of the state medical boards in the US and its territories. And we had a good variety of board roles represented. So we had physician members, executive staff, legal counsel, and public members, and we wanted to get kind of a robust representation of all of the different roles within a board. And we solicited recommendations, and then we had panelists rate the importance of each of these recommendations and have them provide rationales for their ratings. And then what we did is we had panelists read through the rationales of the other panelists so that they can kind of do a perspective-taking exercise and consider the pros and cons and kind of the views of everyone else to sort of understand the rationales and support for or opposition of a given recommendation. So we ended up with a total of 63 unique recommendations that were generated. And we took those 63 recommendations and clustered them into these 5 different categories. I'm not going to go through all of the different recommendations today, but I wanted to kind of give you a bird's eye view of the types of recommendations that panelists recommended. So we had 7 recommendations about the board website, outreach, and education. We had 15 recommendations that kind of bared on improved coordination and information sharing between stakeholders. We had 9 recommendations about board composition and characteristics. We had 11 recommendations about internal board operations and investigations, and then we had 14 recommendations that spoke to licensing and disciplinary considerations. So again, I'm going to highlight 11 of the recommendations that my team and I thought were most salient to addressing physician sexual misconduct. So the first recommendation is requiring that sexual misconduct cases are investigated by specialized gender-diverse teams. So on average, women are more likely to be victims of sexual misconduct than men, so it's good to have representation of different genders on board investigative teams. And gender-diverse teams can lead to more balanced, considerations, discussions, and decisions. And having that balance of perspectives from different genders can also address unconscious biases and implicit biases that might emerge in kind of the self-regulatory environment that happens. As Pat, I think, mentioned earlier in her talk, implicit bias training that can also be provided to help minimize the effect of bias on investigations and decision making. So that was the first recommendation. Now moving to the second recommendation that's transitioning to this different cluster of board website, outreach, and education. The second recommendation is having on the board website an easy-to-find platform for patients and whistleblowers to file complaints. So you want to reduce barriers to entry and make it as easy as possible for people to know where to report and how to report. Really, all of that can help support boards, taking action against harmful physicians when it's easy and simple for people to report. And broadly speaking, like in terms of the board websites, it's good to have good usability and accessibility, not only for patients to be able to file complaints, but to also easily access information about disciplined physicians and to better understand what behaviors are actually reportable to a board. So that's one area for improvement there, something that boards can think about. Kind of related to recommendation 2. Recommendation 3 talks about, on the board website, defining sexual misconduct explicitly and include information about state laws and the board's policy on sexual misconduct. So it is related to that second recommendation, so clearly defining on the board website what behaviors constitute sexual misconduct and when, for example, an intimate exam is and is not appropriate. That can help alleviate concerns and doubts and make whistleblowers feel a little bit more empowered to report. Similar to, in addition to operationalizing what constitutes sexual misconduct, providing information about state laws and board policy on sexual misconduct, that can further empower whistleblowers even more. So when the public knows what actions boards can and will take and that boards are going to actually do something about the complaints that they receive, that's going to make people more likely to want to report and feel more comfortable reporting. And the fourth recommendation is allowing anonymous and confidential reporting to the extent possible. So ideally, the board would be able to contact whistleblowers and allow anonymous reporting that doesn't require the complainant to provide, personal identifying information. That might support an increased likelihood that those incidents are going to be reported. And these information and complaints, these can be used to kind of build a case over time or signal red flags to a board so that they can, perhaps monitor more closely and intentionally. But in cases where complainant information is obtained, it's important to keep that information and their identity confidential to the extent possible. But conveying on the board website how reporting is handled and how confidentiality is maintained and that it is a priority of the boards, and then also kind of talking through in cases where confidentiality has to be breached, providing that information and just being transparent about that process can additionally make those whistleblowers feel a little bit more comfortable coming forward and reporting. So the fifth recommendation, kind of switching gears here to internal board operations and investigations. So that is when the National Practitioner Data Bank, when that has a plausible category to characterize wrongdoing, to ban the use of the categories other or NA, or use those categories as a last resort and require a detailed explanation of why that category is being used instead of the other categories that are presented. So, those categories, the NA or other, they don't really provide super helpful information, and they kind of obscure important details. And another way to think about this is, nothing really permits repeat offenders to continue offending quite like secrecy does. So those categories don't provide the details about the wrongdoing and can result in the wrongdoing sometimes being underplayed and underdocumented. So, it's sometimes the case where attorneys who represent accused physicians, they advocate for these categories because sometimes it can be less damaging to the physician in question. So sometimes they push for those categories. But, requiring a long written explanation as to why none of the other codes are appropriate, that can help stop or reduce the use of the other categories. So the sixth recommendation is requiring that hospitals report to boards when physicians have been dismissed or resigned due to concerns about egregious wrongdoing. So hospitals and kind of the healthcare providers and the leaders within these institutions are in many ways the first line of defense in these cases. So these entities are kind of the boots on the ground who often witness wrongdoing or receive complaints directly. So when a physician is dismissed or is allowed to resign, hospitals might sometimes want to keep events like this in-house and not publicize them, and sometimes that information doesn't get to boards. But sharing this information with the boards can help them in their efforts to protect the public and remove harmful physicians from practice. So the seventh recommendation is somewhat similar, and that's requiring medical schools and postgraduate training programs to report egregious wrongdoing and any disciplinary complaints during medical school as a condition for licensure eligibility. So as the saying goes, kind of the best predictor of future behavior is past behavior unless it's acted upon by an appropriate intervention. So knowing about the past behavior of physicians, even early on in their careers, is a good information gathering practice, right? That can help boards proactively identify red flags and kind of signal when closer monitoring might be needed in the future. Related to that seventh recommendation is this eighth one, which is requiring all physicians to report any disciplinary action during medical school at the time of their application. So asking physicians to provide this information at the time of their application for licensure, that can provide really critical information to boards. Again, it's a good information gathering practice. So tracking this information and data over time, it can help establish patterns of behavior as physicians move, for example, to new medical institutions or new practices, or even hop boards or go across states. And the ninth recommendation is enacting an emergency suspension to prevent ongoing egregious wrongdoing when allegations are credible or a physician has been arrested in connection with such conduct. So I recognize that this recommendation might be a little obvious in the sense that all boards, they have that capacity to enact a summary suspension, but it's not always consistently enforced, and there may be areas of resistance to using it, for example, to protect physicians, and I understand that there's reasons for doing that, but invoking this right of emergency suspension more routinely and consistently, that can really help boards do a good job of protecting the public. And the 10th recommendation is suspending a physician's license when their license is suspended in another jurisdiction. And this relates to another recommendation that I don't have listed on my slides now, but it was allowing for unfettered investigative information sharing across boards to the extent possible. So, boards kind of need to know when a physician's license is suspended in another jurisdiction, so that information sharing kind of needs to happen. And that really just reinforces having a unified approach across boards, and information sharing across boards can help them be a little bit less siloed, and it would prevent, for example, a physician who's being investigated for wrongdoing in one state to hop over to another state and continue practicing medicine without the knowledge of the other board. And then the 11th and final recommendation that I want to highlight is the board should impose penalties on physicians for not reporting peers who engage in egregious wrongdoing. So peers are pretty likely to witness or have knowledge of their colleagues' wrongdoing. They have that duty to report if a peer's behavior is egregious and negatively affecting patients. But with this, I also want to acknowledge there are also kind of structural and cultural factors that may make them reluctant to report. But penalizing peer non-reporting, that can incentivize reporting and convey the importance of peer reporting. It can also signal that the board takes peer reporting seriously. So now that I've covered a couple of those recommendations, I want to briefly address a couple of the barriers to implementing these recommendations. So during the project, in addition to soliciting recommendations, I also asked the panelists to mention some of the barriers that they might face to adopting some of these recommendations. So one of the biggies is that different boards have different access to different amounts and types of resources, and they have different levels of autonomy. So limited access to resources, that can kind of restrict boards' ability to protect patients from harmful physicians, and it makes it difficult to establish and consistently implement policies and practices that are uniform and across all states. And aside from lack of access to resources, one of the most common barriers was that boards had just simply not adopted a formal policy or practice about that recommendation yet. So it was really just a matter of getting them to recognize we need to sit down and make this a plan and implement it, and it's not something that's just going to automatically happen. And I guess the third barrier that I wanted to highlight is sometimes there was a lack of good communication and good communication and good relationships with different stakeholders, and that includes stakeholders like other state medical boards, but also federal agencies like the VA and law enforcement. So when you can kind of work toward the shared goal of protecting the public, I think that can go a long way, and partnering with these different entities to do a good job of protecting the public. So again, I didn't want to leave you hanging with all of these different recommendations and barriers. I want to talk about some solutions for overcoming those barriers. So again, like I said just a few minutes ago, make a plan to sit down with other members on the board and go through the list and identify maybe factors that are kind of low-hanging fruit, those recommendations that are really easy to implement without a lot of legislative change and a lot of resources. Now, I recognize that not all of these will be able to be implemented right off the bat, and they will require legislative change, but that kind of brings to fore the need for good lobbying and advocacy for more resources. I also want to stress the importance of fostering good relationships with other stakeholder groups who share that common goal of protecting the public. So those good relationships and those, that good communication, it really reinforces transparent information sharing, and that can ultimately serve to protect patients. And it's kind of good to keep those shared goals in mind when you're contending with competing priorities. And then I guess the final thing that I wanted to highlight is, old habits die hard, and we kind of get comfortable in the existing policies and practices and norms that have been adopted. But I think that, conversations like this and projects like this present good opportunities for, everyone to kind of test their assumptions and look at their existing norms and practices and think about ways that they might update them or change them to be more in line with kind of the shift in knowledge and shift in norms that have kind of happened over the past several years. So to wrap things up, I hope that boards find these recommendations to be helpful and they can make a plan to adopt and consistently implement some of these recommendations. And I guess to end on a positive note, I would say to not let perfection be the enemy of the good, right? So even if a board can't adopt all of these recommendations right now, that's okay, but they can start implementing some of them now and then make a plan for implementing others. So that is all I've got for you. Thank you for having me.
Thank you. Yeah. Oh, yeah. Okay, I think yeah, great. So our next speaker is Ms. McCollum, and I think we are ready to go here. I'm not the best at this, but I think we're all set. And you can just advance with this.
Okay, thank you. Will that work? Yeah.
I guess you can see it down there too. Is that okay? Great, thanks.
Okay. Okay, hi, good morning, everyone. It's really good to be here with all of you. I'm going to chat with you a little bit about trauma-informed approaches to responding to sexual misconduct. Within that, I also want to chat with you a little bit about cultural humility, which I think the principles of cultural humility, I think, are less known by a lot of people, because cultural competence, cultural safety, cultural awareness, those tend to be the popular concepts that people are dealing with. I'm going to chat with you today about why both trauma-informed approaches and cultural humility can not only improve reputation, response time, inform policy, procedures, and ensure that appropriate supports are available for complainants/victims/survivors, and ensure procedural fairness. There's so many benefits to utilizing both of these approaches when we're responding to sexual misconduct. So hopefully I can share something with all of you today that you didn't know. And I'm just going to build on what was shared with me. So Pat and others had shared a number of reports with me so I could prepare my notes for today. And what I saw was that so far, the FSMB have been doing incredible work, and what I want to offer today is really just building upon that. And I looked at Tristan's report, which I thought was fantastic, and I'm going to offer some content which I hope builds upon all that good work that's already been done. So we know the hashtag #MeToo movement and Time's Up established that leaders must do better. Don't mind the typo. One way to do better is to establish trauma-informed responses to sexual misconduct. Why? Because there's significant potential to avoid reputational harm. When you have leaders who are action-oriented, because that was one of the criticisms that complainants were bringing forward to organizations, corporations, institutions, workplaces, building relationships between regulators and community, create new competency standards for decision makers and investigators, and demand zero tolerance commitment. In addition to that, establish expectations for bystanders and how to respond to sexual misconduct. So the whole, when you see something, say something practice. Before we get into this, I just want to talk a little bit about what trauma is, because it means different things in different circles. And I looked at the report that the working group had put together, and they shared the definition of trauma that was provided by the Substance Abuse and Mental Health Services Administration, which is a fantastic one. It gives you a bit of a framework for what trauma is and also what trauma-informed looks like. What I want to say and maybe add on to that is this. As a lawyer who has done a lot of workplace investigations, as somebody who has been a director of investigations, and I got to see where investigators go wrong, where they make mistakes, where they harm people, I would say that it comes down to a number of things, but one of the first things is a lack of understanding about what trauma is. So, many people think trauma is just this event, this incident, this thing that has happened to an individual, and that given some time, somebody is going to get over that, whatever it was that has happened. What we know, particularly if we listen to folks like Bessel van der Kolk, who wrote many books, one of which is called The Body Keeps the Score, he says trauma is not just the event that completely upends your entire nervous system, but it's also the current imprint of pain, horror, and fear that lives inside people. Why is this important for us to understand, whether it's as regulators or decision makers or investigators? Because just because an incident occurred and some time has gone by doesn't mean that that individual is even in a position to talk about it, never mind being questioned about it, or to give evidence in any public way about what it was that they experienced. If they're living in the state of current imprint of pain, horror, and fear, what that requires from anyone who's dealing with that individual is to understand that when you have all those emotions coming forward, you're going to have to be prepared to respond to that. And what a number of investigators don't understand is how to respond to emotion. Why? Because we're fact finders. Or for many of us lawyers, we think there's no emotion in law. Why should we make space for that? We need to push through and just have people answer our questions. When we take that approach, that is when we do a lot of harm to folks. So if we understand that some people might be living in the state of this current imprint of pain, horror, and fear, that might mean they might need multiple levels of support before they even come forward to officially report what it was that they experienced. And I'm going to talk a little bit about what that looks like in terms of safety and empowerment. The other piece I want to share with you is what trauma-informed means. So we have this great definition on this slide, but I want to just expand on that. So how can trauma-informed approaches be reflected in decisions, policies, procedures, and investigations? First, you have to be able to identify trauma, right? And part of identifying trauma is recognizing that we all have these assumptions about what's a big deal, what's not a big deal. Some psychologists call those like big T, little t traumas. So once you decide and you get informed about what trauma really is, and that it is largely the current imprint of pain, horror, and fear that lives inside people, you have to understand that along with that are triggers. People are triggered when they're traumatized. What does that mean? It means that they tend to become quite emotional. They come out of this place Dan Siegel calls the window of tolerance, where if you're in the window, you're calm, you can answer questions, you are rational thinking. I'd say we're all in that window right now, but when you come out of the window, you go either into a state of fight or flight, which is your survival brain, or into freeze or fawn. And so what happens when somebody is pushed out of their window? They're no longer rational, they can no longer give good evidence, and you've really lost the ability to connect with the individual you're trying to gather information from. A lot of lawyers, I would say, know this because for many of my colleagues, their whole litigation plan is all about pushing people out the window. If you push people out the window, they become irrational. If they're fawning, they're just going to agree to everything you have to say just so they could get out of there. If they're in fight or flight, they're going to be defensive or they're going to shut down. They're not going to say anything. There are psychologists who have said once somebody is out of this window of tolerance, you can no longer talk to them. Why? Because they are not rational. They can no longer give you good evidence. So we have to understand what this window is, what triggers are, why they're connected to trauma. Why? Because if we don't have this basic competency and we're in a fact-finding role, then what ends up happening is maybe the information that we're gathering from people is actually not so reliable. Why? Because they were highly traumatized and highly triggered while they were giving us information. And we didn't make any accommodations for those trauma responses. You also have to be able to depersonalize when trauma presents, in yourself and in others. Why? Because we're all human beings. I don't think we compartmentalize as good as we like to think we do. So if we're going into roles where we're constantly dealing with people's trauma, we also have to acknowledge that that trauma can impact us. It impacts us in all kinds of ways. It can wear down our passion for what we do in the form of burnout. We can experience compassion fatigue, where our cup is empty and we have no more to give. And usually when we're in that state, we become very transactional. And what do I mean by that? We're just simply fact-finding. We're not really interested in your emotions or your experience. We just want you to answer the question so we can move on. That's another space where we do harm to people. So if we understand that if we don't have the capacity to actually make space for the trauma responses of others, we are likely going to harm them as they're giving us information that we need from them. And that's when we lose credibility as an organization, as an agency, as an investigator, as a process. So beyond that, you have to be able to adjust your approach to prioritize safety and empowerment. So prioritizing safety and empowerment means different things for different people. But at the end of the day, it means that you have to utilize empathy. And I know empathy is a tough one for, I know, lawyers for sure. What does empathy have to do with fact-finding? It has a lot to do with it. Why? Because if you have a complainant / victim / survivor coming forward, they're incredibly vulnerable, they are likely terrified, and more than not, they tend to come into these spaces either in their fight, flight, fawn, or freeze mode. So we need to understand that if we prioritize their safety, they are more likely to calm down, come back into that window so that they can have reliable, helpful, fact-finding conversations with us. So prioritizing safety and empowerment goes as far as thinking about what does that person need in order to be here in this process, to show up, to report, to move on and participate in an investigation. They might need a lot more than just a support person. Support person, I think, is a bare minimum. For some people, they might need access to counseling. They might need distraction aids or some kind of tool that they can keep with them as they're giving you evidence and information. That strategy isn't just for children. Like, you know, when kids come into trials, we tend to give them teddy bears or whatnot. I find adults are really just big kids. And we all need something as well to help keep us calm as we go into these spaces. So prioritizing safety and empowerment really requires, first and foremost, just connecting with people and asking the question, what do you need to feel safe in this process? Safety has to be a question that we ask people because it means different things to different people. But if you're dealing with people who've had like a lifelong history of victimization, they won't know the answer. And so there should be options that you can default and offer to an individual, and then they can pick and choose what could work for them. It's really important that when we deal with complainants and victims and survivors, that we don't really dictate the process, that we give people a lot of options that they can pick and choose from. I get that our processes are really quite structured and rigid, but within there, I think, is some flexibility to allow people to feel empowered and that they have some degree of personal agency when they show up into our processes. The other piece is you have to adapt your plan to accommodate trauma, right? Yours and theirs, because your mental health has to be intact in order to be able to connect with people. It really does, because if your mental health is not okay, nobody's going to be okay in those spaces when they're working with you. So what does that mean? Adapt your plan to accommodate trauma. It might mean that you take more breaks. It might mean that you pause and you give the person you're dealing with opportunities, many opportunities to answer questions. It might mean that you think about the configuration of the spaces that you've created. If you're doing an investigation, think about the room that you've created for those investigations. What kind of table do you have there? Brene Brown, who I know Americans love, she says that circular tables, they create connection. But these long kind of boardroom tables where we sit opposite each other, that can create a state of conflict or a perception of conflict, or now we're in an adversarial situation. So we have to be really mindful about the kind of environments that we create for folks, including where do you sit in the room? Where does the complainant sit? If they are in their survival brain, they're going to want to sit closest to the door. Why? Because that's the thing that allows them to leave really fast. You prioritize connection and relationship by engaging with humility and compassion while checking your biases. So this really is, I would say, I have to acknowledge Dr. Melanie Turvalon and Dr. Jen Marie Garcia. They came up with the cultural humility framework after the beating of Rodney King, and they began to think about justice, equity, and fairness. And how do you bring that into the healthcare field, into their backyard? And so they looked at cultural competence and cultural safety and cultural awareness and realized those frameworks don't go far enough. Why not? Because they're really goals. What can I read? What can I do? What course can I take that now positions me to work with you? Whereas cultural humility is more of a relationship-based framework. It's built on lifelong learning, a commitment to self-reflection, self-critique, and really getting in touch with your unconscious biases. The unconscious bias piece is so important for us to be checking in with all the time. Why? Because they don't always align with our personal values and beliefs. They're the things that creep in when we're not really paying attention, and all of a sudden we're like, whoa, when did I start to think that about that person or about that situation? And I think unconscious bias is particularly something that we have to be alive to if we're dealing with sexual misconduct. Why? Because we know that there are so many myths and stereotypes and victim-blaming practices when it comes to survivors, complainants, / victims of sexual misconduct. And we don't always know that we have these ideas and beliefs in our mind until all of a sudden we're talking to somebody and it pops up. Finally, you safeguard your mental health by understanding vicarious trauma and vicarious resilience. So one of the ways I've seen organizations and employers do harm when they're creating trauma-informed approaches, whether it's in their decision-making, their policies, or their procedures, or their investigations, is when they don't make space for recognizing that burnout, compassion fatigue, and vicarious trauma is a real risk factor. So if you have an investigator or a decision maker who is worn down, burned out, experiencing compassion fatigue, or is traumatized by the content of what they're hearing, they're not going to be able to make good decisions. They're not going to be able to connect with people in an empathetic way. They definitely are not going to be able to prioritize safety and empowerment for whoever it is they're dealing with. Why? Because they haven't been able to do that for themselves. So we have to talk about things like emotional intelligence when we're thinking about who it is that we engage to do our investigations and to make decisions about our policies, our procedures, and any other big decisions. So I want to just add trauma-informed. It means different things in different circles. We know this is kind of like a sexy catch-all topic these days. And it's rooted in trauma-informed care. And what I want to say about trauma-informed care as it's understood in the healthcare field or in social work, it's very different from what I'm talking about today. Why? Because as a lawyer, I'm not a care provider, nor have I ever been. And I think if you asked me to do that, I probably wouldn't do a good job at it. I work with evidence. And that's what I'm equipped to do, that's what I'm trained to do. So trauma-informed, whether it's lawyering or investigations or decision-making, is really about remaining impartial, neutral, fair, being able to assess evidence, and being able to do it in a way that doesn't favor any particular side, but that understands all of the complexities that are occurring in these spaces. So one of the things that I want to comment on is we have to think about the language we use when we are talking about sexual misconduct. At least I know in Canada, there's a real push against using the label victim. Why? Because it's a disempowering label. A lot of survivor groups are pushing against it. Some people opt for survivor. I, as a lawyer, opt for complainant because it's just a neutral label. But we have to think about labels and the weight that those labels carry. I also want to acknowledge that being survivor-centered is very different from being trauma-informed. So trauma-informed is about recognizing the trauma in all of us, whether it's a complainant or respondent, the investigator, whoever, and then making space for all of that. Survivor-centered is about prioritizing the needs, the safety, and the supports of simply the survivor, complainant, victim. Historical content, we have to acknowledge that in our history, there have been stereotypes, myths, victim blaming, and practices of protecting perpetrators. You know this very well, I know this very well, and we have to acknowledge that. Why do we need to acknowledge it? Because I would say a lot of survivor groups on both sides of the border have criticized organizations who are dealing with or responding to sexual misconduct to say, before we find a new way forward, and before we take up the hashtag, Me Too commitment, we first need to acknowledge where we failed, where there's been failure. If you want someone to trust you and see credibility in your message or in your efforts, there has to be an acknowledgement of failure. In the criminal justice system, I talk about this all the time with lawyers and judges and other leaders, that there has to be an acknowledgement of where we failed, and then we can talk about our commitment to do better. And so the failures are always centered around stereotypes, myths, victim blaming, and the big one, which is protecting perpetrators. Intersectionality is something that we all have to think about. Why? Because intersecting systems of inequity help us identify who's the vulnerable person. And so as I was reviewing all these materials in preparation for today's presentation, I kept asking myself, who is the vulnerable patient? I know that statistically people will just simply say it's women and children, but I also know, at least in Canada, there's significant underreporting of males who experience sexual abuse. Why? Because of the stigma. So we don't actually know the numbers of how many men and boys who are being sexually abused by, physicians, others. The other piece is we have to think about the queer community. At least in Canada, this is a conversation we're having a lot about how members of the LGBTQ community are also really vulnerable for victimization. In addition to that, we have to think about race and class, survivor status, body size, the whole range. Why? Because if we're not thinking about the whole range beyond women and children, we're leaving out a massive group of people who are experiencing vulnerabilities and victimization and who are likely being targeted for grooming. And I think about a lot of individuals who are poor, who don't have the same socioeconomic advantages as maybe, folks who experience like white privilege on the regular. We have to talk about white privilege. That's a component of cultural humility as well, is checking on how does privilege show up in our processes? How does it create power imbalances? How do we establish individual and institutional accountabilities that acknowledges white privilege and how it shows up? So intersectionality means we have to look at the whole range of all the different types of people that are showing up in these spaces, likely being victimized. Unconscious bias, I talked to you about that a little bit, but we have to constantly self-reflect and self-critique, right? What do I think I know about how credible people respond to sexual misconduct? I mean, all we have to do is look at criminal case law to see all the myths and the stereotypes that have emerged when people have been assessing whether or not somebody is a credible complainant. We have to challenge ourselves. What do I think a credible complainant looks like? And this, as soon as we start to think to ourselves, well, why didn't you just say something? Why didn't you just do something? Immediately what we're doing is we're victim blaming. Why? Because we don't all respond to sexual misconduct or sexual abuse in the same way. And you also have to remember this piece, and this one is kind of around privilege. And I think a really good example right now is Bill Cosby. You could be two things at the same time, right? You could be America's dad selling Jell-O, and you could also be raping women, right? And we have to really wrap our brain around that, particularly when we work in environments where we hold people up really high and we're like, oh, but he's such an amazing leader or an amazing doctor. You could be those things, but you could also be this. And so it's important that we confront these ideas, because if we don't, we will either consciously or unconsciously be protecting perpetrators or giving them advantages that they haven't earned or they don't deserve. I want to comment on the assertive person bias. Why? Because as I was reading the report, something had come up for me when I was seeing this comment about, if you feel uncomfortable with what a physician is doing, say something. Ask the question, why are you asking me to disrobe? Why are you asking me to submit to this exam? If you have an individual who is assertive, that's a reasonable ask, to put the onus on them to ask for accountability. But if you have somebody who is a child, who has a history of trauma, who is powerless, who is less sophisticated or educated, they're not going to say anything. They're just going to be very quiet. Why? Because silence seems to be the common thread amongst these groups. And as Dr. Gabor Mate was on my podcast, and he's known as this worldwide trauma expert, he had said to me that particularly perpetrators who groom individuals know exactly who to groom. They look for indicators immediately as soon as they see someone, and they can identify who is the perfect person to begin grooming. And so for people who have a history of repeatedly behaving in this manner or offending in this manner, they know exactly who to target. And this is why, similar to the church, when you don't report and you let people move to another state or another location, the pattern of perpetration just continues all over the place. So we have to be really mindful about this assertive person bias. Not everyone is assertive enough to go, hold on, let me ask questions. Because we also have to understand that there's a power imbalance. If you feel powerless and you are poor and you need to see a doctor and you're being asked to do things that inside you feel is really inappropriate, you feel uncomfortable with, you may still submit and then just leave. And then hopefully, in your mind think, I hope I never have to come back. Access to information. I read in some of these reports this idea about patient navigators, which I think is a fantastic idea. I also think that beyond patient navigators, there has to be outreach and community connection. Because I know from the work that I've done, when people have been sexually harassed or sexually abused, they will often go to local community rape clinics and they will disclose there. They don't normally go to the spaces that we've created for them to disclose. They don't call the number to report. They will go to a local clinic and they will tell somebody in their community what has happened, if they say anything at all. I think it's really important to have plain language available, whether it's in posters or whatever it is that you provide to patients to help them understand what their rights are or what they can expect from their relationship with their physician. Why? Because plain language is critical. We don't all call things the same thing. Sexual misconduct. In my hundreds of interviews with complainants, I have never heard them call it sexual misconduct. We don't all use the same language. We don't even have the same language for body parts, genitalia. I've heard so many different versions of what that is. So we need to think about language barriers, and we have to think about culture barriers. Okay, so I know my time's almost up. I want to just comment on racism, because I didn't see that enough or maybe at all in the materials I read, and I just want to talk about the BIPOC experience, Black, Indigenous, people of color. So, Heidi, who's in the crowd, knows, and I know in Canada, there's a lot of media coverage in recent years about the treatment of Indigenous people, my people, when they come into a healthcare system. And it's usually race-fueled, and it's an adverse experience. What I want to say is where racism is systemic and as it's experienced by members of the BIPOC community, it has to be expected that sexual misconduct or abuse experience is not going to be reported. Why? Because there's no relationship, no trust, and no recognition that BIPOC patients are experts in their own lived experience. We have to understand the intersection here. If we're not talking about how racism exists in these spaces for these individuals, we can't begin to talk to them about sexual misconduct. I think more work needs to be done to figure out what exactly their experiences are when they come into these spaces. The only thing I want to just leave you with in this short presentation that I'm trying to jam a lot of information into is that setting these new standards for what it means to be trauma-informed, what it means to be accountable to survivors, complainants, and victims, whether it's in policy, procedure, or investigations. It really has to start at the entry level, so colleges. So I've worked with UBC in Vancouver and the U of T in Toronto with their colleges of medicine to discuss some of the barriers that they were experiencing and trying to find a new way forward in terms of helping people feel comfortable to report. And the problem is, because of privilege and power imbalance, there is so much fear. And so the silencing becomes it starts really early. And so, I think as we go forward, we have to think about how everything we model at the entry level is going to trickle down as people come into the profession, become physicians, and find communities to work in. And yeah, and that's it. Thank you for listening.
Thank you so much. We have some time for questions. These two, thank you again so much. It was just really wonderful to share your knowledge and expertise. But if people would want to come up to the microphones, if they have questions or comments or experiences with their own state or their own participation on state boards. There's someone at microphone 2. Okay, if you could identify yourself and your state board and then direct your question. Thank you.
Wonderful, thank you. Gigi Chawla from Minnesota State Board. Thank you so much for your conversation and talk this morning. I think the other group of vulnerable patients who you didn't mention are those with a mental health condition already. And those have been the toughest cases for, I think, me personally to check my bias before I even review the record. I wonder if you have any data on how often some of the sexual misconduct cases, what the end results are for those who have mental health illnesses to begin, or any tips for us as clinicians reviewing these cases to check our bias, especially around this population. Thank you.
Thank you for that question. You're right. I didn't mention that group of people, and I'm thinking about other groups that I didn't mention. Like, I'm thinking about people who live with disabilities, people who have addictions. There's a lot of vulnerable groups out there. I don't have any data for you. I'm really sorry. And I think the only thing that I can offer right now, at least, is a bare minimum, is for us to check our biases, to really assess, what do I think about people who are living with these experiences? And if I don't think that I could be objective or impartial or fair, then we may have to build some strategies that can help us get back to that place when we are working with these individuals.
Great, thank you. We'll do these questions. We'll go a little over, but we have a pretty long break, so I think that should be okay. So, Scott, go ahead.
Hi, good morning. Scott Steingard, past chair of the Federation. Thank you all for a wonderful conversation and very enlightening. And thank you for keeping the conversation going, Pat, because this is something that we need to continually push forward for our state medical boards, because it will get lost in the shuffle if we don't. And this is a question, a little background. I was fortunate enough to be on the committee that when we first started assessing this, and one of the groups I wanted to talk about, which we didn't mention today, but I was just kind of a follow-up for Pat to address, welcome to have both of you talk about it. We had medical students who testified in our committee about attending physicians with a sexually inappropriate behavior toward the medical students. And we did address it in the paper, but I wondered if, and I don't know if there's anybody here from AAMC or ACOM to talk about, have we had any follow-up with the medical schools regarding how a medical student should respond if they are treated inappropriately? And I don't know if we've heard anything since then. Thank you.
Sure. I know because I'm at a medical school that this is followed very closely. There are avenues for reporting. But again, it comes down to what Myrna was, there's a power differential, and it's very hard. So you might remember Jerry Hickson's program at Vanderbilt that really tries to normalize reporting, starting with really low-level reporting and then kind of build that normalization. That's what we do at Vermont. We actually report both complaints about people as well as positive comments about professionalism. So that, again, just trying to normalize it. I don't know if any of you have more information.
Yeah, Pat, I totally agree with everything you just said. And at WashU, also medical school, there's a system that we've recently implemented, and I'm not directly involved with this, but it's a reporting system where any trainees can report the behavior of attending physicians or anyone who's providing educational instruction. And I think it's good to have those reporting mechanisms in place and encourage it. I think that there's a lot of fear of retaliation, and that's causing a lot of that resistance to report. So the extent to which leaders at those institutions can protect or inoculate against that retaliation, I think would further support increased reporting, and also just the whole way it unfolds. I think it supports better approach to that.
Did you? I think maybe I'll just add the piece around why anonymous reporting is important. Of course, we know that there are some challenges with anonymous reporting, but I think that we're at a place where people can explore sort of how can we expand anonymous reporting to maybe include third-party reporting, so it's not the receiving person of this behavior who has to step forward and call it out. This is why things like bystander training is so critical. If you see something, say something. And what is your obligation if you hear something or you say something? The other piece is I've had conversations with leaders to explore this idea about this duty to inquire. If you have heard one or more or like maybe a threshold of disclosures about some behavior, what is your duty to inquire? And that doesn't mean you're triggering an investigation. It doesn't mean a report has been submitted. It just means you're telling the perpetrator you're now on alert that people have said something about you.
Thank you.
There are some legal implications with that too, but.
Microphone 4. Well, so we'll do microphone 4 and then 3. Heidi?
Yeah, thanks. Heidi from British Columbia. Has there been any action that is available through either looking at discipline decisions or notifications or things like that where an action has been taken against a physician for failing in their duty to report? And the reason I ask if there's something out there that we can look at is our government is currently redrafting our legislation that governs how we regulate the medical profession, and we have been pushing for a requirement to actually have some consequences for not reporting. And we are really trying in British Columbia to use the concept of a speak up culture, that we actually are holding health professionals accountable for misconduct broadly, because it can't be just left to patients to decide whether or not they've been at the end of bad conduct by health professionals. Health professionals have to be there to call it out as well. So I'm just looking for anything, and maybe we could offline look at that, but if any state boards have anything that they've done, because we'd like to look at that.
I think, I see Stephanie Uka from Ohio. I think Ohio has disciplined someone for not reporting already. And I think there are some other cases that I've read about. Maybe Tristan, I don't know if you know of any, but I definitely know Ohio has. And Stephanie can talk with you, yeah. That would be great. Microphone 3.
Naveed Razak from state of Missouri. Just want to talk to you about subset of sexual misconduct complaints that we see, and it has to do in the exam room. He said, she said, and there is no chaperone. So by the end of the day, we just say, well, the chaperone was not there, so she must be saying right. And we lean towards that. And we don't really know. We have a response from the physician as to what happened. We don't really have the complainant to really interview, because interview happens by investigators and stuff. But personally, when we are making decisions, as it's he said, she said, how do you really approach? As I said, by the end of the day, we say, well, there should have been a chaperone. But if you look at the standard of care, that may be the best practice. But majority, if not, majority of physicians really don't have chaperones in their, when they are conducting exams. That is the going. It's not a standard. But when we are judging, we say, well, there should be a chaperone. That is the best practice. So how do we address that issue, he said, she said, and then who is the victim then? Is it the physician? Maybe someone from the other side is trying to just get some physician into trouble, versus maybe the physician was wrong. How do you really address that issue in the exam room?
I don't know if you do either.
Well, I mean, I can't talk about exam room conduct exactly, because that's not my wheelhouse. I can talk a little bit about the he said, she said piece. I mean, a lot of sexual misconduct cases come down to he said, she said. Why? Because you don't usually have a third party present when rape is occurring, for example. So that usually comes down to, having a really qualified and competent investigator doing the fact finding on your behalf, because they can suss out credibility and reliability. And I believe, like in America, like in Canada, the burden of proof is really on a balance of probabilities. And so there are consequences, of course, in terms of employment for individuals who've been found on a balance of probabilities to have engaged in this conduct that they're accused of, but recognizing, and I think investigators need to understand the difference between, proof beyond a reasonable doubt that you find in a criminal courtroom and what you find in this workplace type investigation. And what you might end up getting oftentimes, I know, as a former defense lawyer, I would always tell a client, do not say anything, because anything you can say can be used against you when you come into a courtroom, if you come into a courtroom. So there are a lot of challenges if you don't have a participating respondent. And but there are also so many challenges when it is a he said, she said, which is why you want to have really clear competency standards for any investigators that you hire to do this work. They need to know what they're doing, and they need to know, and you shouldn't hire criminal lawyers to do this work. No hate for all my criminal lawyer colleagues, but yeah.
Thank you. Tristan, did you, out of your 101 cases, did you talk about the he said, she said?
Yeah, I'd have to think back in detail. It's a tough question, and I think one thing that could help with the he said, she said dilemma is that kind of sort of what I talked about in my talk about information gathering early on about behavior. So if you can, build a case, or if that physician's, had complaints made against them previously but nothing was acted on, that can help give you a little bit more confidence in that he said, she said. If there's other, sort of adjacent evidence, I guess you want to say, that can help sort of suss out that and further kind of corroborate, what ended up happening.
Great. Thank you. I think we're over our time, so I'm going to have the other two people come down. I would just like to give a round of applause for our speakers who've done a wonderful job. Thank you.